Yeah, that's perfect.
Alrighty. So I'm going to start the stream now.
Sounds good.
Let me just make sure it started. Okay, perfect. Alrighty, hi everyone. Welcome to another Dental Shadowers virtual shadowing session. Thank you for tuning into our session today. My name is Dia, and I'm part of the Dental Shadowers e-board. I will be facilitating today's session with Dr. Judy McIntyre, an endodontist. Thank you so much for taking the time out of your schedule, doctor, to meet with us. Whenever you're ready, the floor is yours.
Thank you so much for having me. I'm always thrilled thrilled to share my passion for what I do. I am pretty passionate about what I do. So thank you for your interest and for asking. And I'm enthusiastic to be here. Thank you for having me. So I'll just get into it. So I became a dentist first and foremost because I had a dental trauma at a young age. So most of what you're going to see, you can see I have cropped from my Instagram page. So if you ever want to refer to the content, not specifically this picture, but the dates are down below if anything interests you that I'm talking about. So at around age 7, I was at a playground. It was a field trip, and they had a huge like cement boulder at the end of the playground, and there was a ramp. And I ran down the ramp, and my feet got ahead of me, and I smacked my face into the cement boulder that was at the end of the playground. So needless to say, you can see from the pictures, it was a pretty bloody scene, as dental trauma usually is. And I remember kind of looking down at the ground, and there's sand everywhere and dirt everywhere and blood everywhere. And obviously ended up at the dentist. He did not do anything that day. Sometimes in dental trauma, that's typical, but it laid down the path. It was a very formative experience, and it laid down the path because, as many people know who have had dental trauma, as you can surmise, once you chip a tooth, it's really hard. And, obviously this is a long time ago now, and composites and bonding have improved, but that piece was, hangs on by, resins, which is like glue. So every time a young active kid will eat a pretzel, for example, or get in a pillow fight with her sister, that piece is going to come off. So needless to say, I spent a lot of time at the dentist. And, once I started thinking about things, I figured it seemed like a nice lifestyle. I always liked arts and crafts and things to do with my hands. And I thought that it would just be a great profession for me. So I felt like early on it suited me well. And from then on, I was pretty determined to become a dentist. All of my childhood friends will tell you that I've been talking about dentistry since a young age. So I went to college, and while I was in college, I picked up the phone book and I started wanting like a summer job and wanting to shadow and learn more about dentistry. So I went through every dentist in the phone book, and this lovely woman named Dr. Brown, Dr. Patricia Brown, who's still in practice, came to the phone, and she said, come over anytime I wanted. And she had a beautiful office. It was a block away from Newbury Street in Boston, downtown Boston. And I spent as much time with her as I could, and she trained me. Back then, I was trained as a hands-on dental assistant, and she let me place brackets and wires, and not brackets, excuse me, wires and some of the bands that get tied around the brackets. She let me do a lot for being in college. So I did that for, as much as I could for 3 years. And when it was time to apply to dental school, she kind of said in passing, why don't you apply to Harvard, which is where she had gone. And I was just kind of like, yeah, whatever. Who do you think I am, lady? Like, I'm not going to get into Harvard. And at that point, I had already been applying to a lot of the dental schools. So my application was considered pretty late in the game. So I did get the interview, and I applied, and sure enough, I was like the second to the last person admitted into the class. And so I did end up going to Harvard, and that was a great experience. When you apply to dental school, something that you should think about, which was pretty ingrained in me. I did not particularly want to go to a dental school where they also did medical school. I knew this whole time I was not interested in medicine. I did not want to go to medical school. I didn't want to be with medical students. I just wanted no part of it. So I was going against everything that I had pretty much told myself. Nevertheless, they did and still do have a pass-fail system, which I think worked in my advantage because it allowed me to relax a little bit. And with my personality, I think that worked again in my favor. So after 4 years at Harvard, I was in, and this is now like my 8th year in Boston, I was freezing cold. I'm originally from Los Angeles, California. I was pretty grumpy and miserable. I'm like, I'm out of here. So I applied to endo residencies. At that time, I had decided I would become an endodontist in my 4th year, pretty late. And I ended up applying and I got accepted to UNC, and I loved Chapel Hill. I went to UNC and just loved every minute of it, loved being there, loved the sun. It's a beautiful place to live. You know, my co-resident is still a friend this day. Like, you know, he's one of my bestest friends. And we just had a really great time. And obviously I was under the directorship of Dr. Martin Trope, who is a world famous endodontist. So I learned a lot. And at that time, this is back in 2003 to 2006. So at that time, we were doing a lot of really groundbreaking things in terms of the endodontic specialty. Now they're more commonplace, but way back then they were really, really cool. We were moving teeth around. I did an auto transplantation in residency. We were trying to grow teeth, regeneration, and just all of these things that really were on the cutting edge. And he was letting us do everything. Part of our residency also was that we would go to prison every week. So part of that experience was, again, amazing. And that's where we learned a lot. We were trained in surgery and became quite adept in surgery. So again, it was really just a great experience. There's nothing like saying you can walk in and out of prison in the same day. So it was a really beneficial experience. And like I said, it really trained us well. And we did a lot of great work. So after residency, I had an associateship down in North Carolina, and then we moved back to Massachusetts. And I traveled around as an itinerant endodontist, so kind of within the general dental office. I would come like once a week and do the root canals. And I did that for about 10 years. And then about 4.5 years ago, I opened my own practice in Hopkinton, which is where the Boston Marathon starts. And so it's a tiny office. It's really, really tiny, but it's all I needed. The dentist who was there before me had already vacated and retired. So the plumbing was all there, but it was basically a shell minus the one of the center cabinets, which I'll show you. But, you know, in part of this experience of DentalShadowers, you know, one of the things that was so great was that it was already plumbed out as a dental office. It's not totally ideal in terms of what I had been designing in my head or what I had ever dreamed of, but the space was there. And when you see a space that's already plumbed and ready to go, it can save you hundreds of thousands of dollars in terms of your build out. And negotiations with your landlord and all of that stuff. So it really kind of was just perfect for me. So I opened in the fall of 2016 after having traveled for a while. And currently this is my assistant and this is our website. So this is Marina and this is me. And this is pretty much my only operatory, my only chair. I have a consult chair, but I only do consults out of that. So really it's a 2-op practice. I call it a 1.5-op practice, but it's a tiny office. This is my building. You can see it's an old colonial building. It is historic. And basically this is the waiting room. This is the op 1. This is op 2. And then upstairs is my office, the break room, storage, and in our little lounge area. So it is pretty tiny. It's not ideal that it's on 2 floors, but it works for us. So this isn't the other view. So again, like I'm in that little corner, like back tucked away. So people park here and they walk in through this door on the side. And this is my little building. A little bit about Hopkinton. It's quite bucolic. It's quite lovely. It's important. That's important to me. We all 3 of us walked down here last week. It's lovely. What's not to love? It's on Lake Whitehall, and I like it. This is a bit of our office tour, which you can find on our website. So all of these pictures, our waiting room and the front desk area and the comb beam machine. And again, this is a little bit of a closer view of my operatory. So you can see for an endodontist, most endodontists work with a dental microscope. This is my endodontic rotary machine, my apex locator, my ultrasonic right here, high speed, slow speed, air water syringe, and then my assistant has her own stuff on her side too. So again, this shows you the whole office. So again, op 1 and the consult room. So pretty tiny in here. And then this is our sterilization area. So in terms of advice regarding future dental students or pre-dental students, I really would encourage everyone to shadow a dentist or a dental specialist. And when doing so and when reaching out, I think both younger and seasoned dentists and dental specialists are important. I do know that within, my class in dental school, 2 people did drop out. It's an expensive and it's a long and it's a tiring commitment. So you want to really be sure that you're in it for the long haul. It's not necessarily the easiest profession. My dentist actually tried to talk me out of it. It does wear on you. I'm not going to lie, especially depending on how you practice. So definitely talk to as many people as you can and see people at the beginning and middle and end of their careers and, pick their brains about the pros and cons. Also, you don't have to go right from college to dental school. Some people take a gap year. You work in the office as a dental assistant, get trained. You can work as an admin. I know I probably should have done a little bit more of working as admin or work in the back to learn how to sterilize your instruments. Because when you open your own office, they don't teach you how to really run an office in dental school, and they don't teach you anything about sterilization. And you have to know all of that. At the end of the day, it's your license and it's your, if the board is going to come and they're going to check your stuff. And when they do, you're ultimately responsible, even though, you have people assigned to those jobs. So you need to know how to do all of it at the end of the day. Also talk to dental students. And, as you're learning things, follow, there's so many great dental social media accounts that I love. I wanted to share this picture because both of these lovely ladies have been in the office in some aspect over the years. So Camille has actually sweetly returned for, I think, 2 or 3 years, 3 summers in a row. She is now going into her 3rd year at Penn. And Peyton, who is 1 year younger, took a gap year. She worked as a dental assistant in a pediatric office this past year. And she is going to Penn also in the fall as a 1st year. So I just can't say enough about interning and getting experience and really just, showing yourself and learning things. I will say both of these ladies have learned a ton, whether it's in my office or in another office. Camille has learned so much about admin, which I never knew going into dental school, and learn x-rays. I would say that both of these ladies can really look at x-rays in a very critical manner from their experience, which, because I'm an endodontist and I look at more than just the tooth on an x-ray, I would say that that's super important. Some dentists that I know still might not be as good in terms of looking at the whole tooth, and really that I can't say how important it is when you're evaluating teeth to look at the whole tooth. So what is endodontics? So I know I'm not the first endodontist that has been on here, so I'm going to just kind of go really quickly through this. So endodontics is the inside, right? Endo being inside of a tooth. So a root canal, you can go to the AE website and learn more about root canals. And I do want to just increase awareness that there's so many things on our profession's website in terms of myths about root canals and what is a root canal. So these resources are out there, so I won't exhaustively go into them. But basically, there's pretty much two reasons why you would need a root canal. So one is basically you get a cavity, and then either the cavity is big or not big, but let's just go with a big cavity. When a big cavity encroaches the nerve, and every tooth has a nerve inside, right? So you pretty much see this part of the tooth, and everything under is inside your bone and gums. But when a cavity gets too close to the nerve is going to start feeling it. It's going to get inflamed. And ultimately, this is a closed system. Unlike the rest of our body, it cannot heal. So when it cannot heal, it essentially dies. And the tooth can become symptomatic, and it cannot become symptomatic. But once it's dead or in the process of dying and it's inflamed, you come and need to see me. So when that's like a big cavity. So sometimes also, though, over a person's lifetime, there can be like a medium-sized cavity, you get a filling, and then over 20, 30 years, you need a crown. Anyways, the point is that over a lifetime, the more and more dentistry a tooth has, the more it gets those restorations, or the cavities get close to the nerve. Again, you'll need a root canal. So it's all about, again, proximity to the nerve, insult. I like to say to my patients, everything needs its own personal space, like we all do. So the nerve does too. And anytime it's really encroached upon, it's gonna react and have symptoms. The other thing, which is quite a large part of my practice, is dental trauma. So like I experienced, there's different types of dental trauma, but sometimes dental trauma will ultimately need a root canal. And depending on the degree of the dental trauma. So again, I just wanted to redirect anyone who's really interested to the AE web page in terms of, more details about a root canal, is what symptoms are indicative of needing a root canal. Basically, my big thing is healthy teeth never hurt, right? Like, how often do we think about our teeth? We really don't think about our teeth. We brush them, we hopefully floss them. But teeth, you don't feel your teeth. You don't have a toothache when you're eating or drinking or biting. So when you do, there's a problem. And that's when you need me. And some symptoms, again, on the AE website, basically most people complain of hot or cold sensitivity when they have a toothache. And those are pretty much most of the dental symptoms. Obviously, there can be swelling, there can be severe pain. Anytime you don't sleep well and you think it's because of a toothache, that's, again, another reason you would need a root canal. So some of the procedures that I do are obviously root canals. And then I also do a lot of redo root canals. And I also do endodontic surgery. It's also called apicoectomy. And then I diagnose. A huge part of endodontics and our specialty is diagnosis. So, if a tooth is cracked, it's my job to figure that out and figure out whether or not it's worth saving. Again, I spoke about the dental injuries, and those are the pretty much all of the procedures. So it doesn't seem like quite a bit, but it surely can keep you busy, and there's varying complexities of everything that I do, and I'll get into that in a bit. So if you go to my Instagram page, you can also see some of these procedures on there as well. So if, again, you want some more details, feel free to go there. Here, for example, would be an endodontic surgery if there's an infection and, for example, the patient does not want to go through their teeth. I make a small incision in the gums, I push back the gums, and then I scoop out the infection and plug it from the upside down end of the root and then close it back up with sutures. Some other things that I do are redo root canals, and that's when I have to pretty much take apart a tooth or try to partially take apart a tooth. And sometimes there can be things in my way to get down to the redo of the root canal. And this would be a post that I had to get out to redo the root canal. So there's things that we take out of teeth. A lot of teeth are filled with, this is pus. So a dental infection can sometimes make a tooth really throb, and it's because it's essentially pretty much a glorified zit up in the tooth's root, and it needs to go somewhere. So whether I make an incision in the gum or open the tooth and let it drain, this is probably one of the best pictures I've ever taken of pus inside a tooth. And then this is again a redo of a root canal, taking the thermophil carriers in this case out. So these are all pretty technically complex, right? Like obviously residency. I went to dental school and then I went to residency for several years. So you're learning this not overnight, for sure. So I did speak about diagnosis as a big part of my practice. So pretty much every chart note looks something like this. And then WNL means within normal limits. But when it's not within normal limits, that's when I change this grid and we'll fill in, plus, minus, plus, plus, plus if somebody's hurting really badly. And that's where essentially I kind of do the thinking. I wanted to say do the math, but like I look at this grid and I figure what stands out here, what is the most abnormal in terms of teeth, because sometimes I do have to look at several teeth, and from that I can make a diagnosis and decide where I should be treating and the focal point of their pain, because sometimes also patients can't really tell, and then I have to make a decision and grade it. So like, when you go to the optometrist, which is better, one or two? It's kind of like that sometimes, especially more so with the lower teeth when people really can't tell. So today I actually had an amazing patient, one of my favorite patients, and I did record some of my pulp vitality testing. I don't know that we want to watch each one, but I'm happy to share some of them. This might not work the way that I embedded it. Yeah, I don't think so. So let me just go back here and then so this is one of my pediatric patients who has had dental trauma in the past. So this is the percussion test. So basically it's literally taking your mirror and tapping on each tooth. You'll see some practitioners tap on the front part of the tooth, which is called the facial aspect or buccal aspect of the tooth. Really, I always go incisally, because if there's any kind of inflammation, they should feel it in the tooth's direction, like when they're biting. So that's percussion. And you can see, I hope it's conveyed. I'm not tapping very hard here. It's just light tapping. So this is palpation, which is essentially pushing on the patient's gums, because when there's an infection and bone loss, usually a patient will report palpation sensitivity. So here is the palpation test.
So I don't think we can see it. I'm
Oh
checking
no.
watching. Yeah, did you share just the PowerPoint? It might be because you just
Yes, it is.
see.
It is. And I don't know if I can go back. Let's see. Let's just proceed, and maybe I can do it at the end
Yeah.
because I don't want
Yeah,
to.
no worries.
Okay.
Yeah, no worries.
Okay, thanks. Oh, that's a bummer. Okay, so proceeding on. Here, how about I just talk about this? So with percussion, basically you're taking the end of the mirror and you're tapping on each of the tooth. I do it super lightly. I've been told I do it super lightly. I just don't think that, the harder you hit a tooth is going to make the patient really, they should just be able to distinguish subtle changes. Same thing with palpation. It's literally touching the gums around where the root tips are along each tooth. And if there's bone loss, it should feel like a little bruise. Cold testing is spraying a cotton pellet with super, super cold, like a can of ice, which is negative 32 degrees Celsius, and putting it on each tooth. And if you do that, healthy teeth feel cold. So when a tooth doesn't feel the cold, I would write a negative response on that tooth, and usually indicates that the tooth has died. Perioprobing is PP or PPD, perioprobing depths. And that's just like when you go to the hygienist and get your teeth cleaned and they measure your gums. Normal healthy gums are around 2 to 4 millimeters in depth. Again, some people, when you probe, they're like, oh, that hurts. And, it doesn't feel great, but it's not whether it hurts or not. That is the test. It's the measurement, because when a tooth is cracked, usually that crack will be like a 5 or a 6 in a measurement. So I try to be quick about this because they do pretty much complain about the probing. Biting is basically biting on a Q-tip and seeing if it hurts when they bite down on the Q-tip, and also when they release on the Q-tip, whether it bothers them. And then the electric pulp tester is what I'm going to show in the next slide. So basically it's a wand, which you can see my favorite patient here holding the wand. And then what I do is I have a little smear of toothpaste on my glove, and I get the wand and I dip it in toothpaste. And essentially he's making a circuit with the machine. And here's the toothpaste. So that any sort of, it's essentially an electrical current, but I don't want you to think like I'm making him like zap or anything like that. It feels like a warm tingle within the tooth. So just like the cold has its own test, this is called the electric pulp tester, or vitality scanner, made by Kerr Endo. So he's making a circuit with it. And so when my directions are, when you feel the tingle, let go of the wand, because he's making the circuit with that. And so when he lets go, he interrupts the circuit so he doesn't sit there and tingle longer. So the other thing that I do that I spoke about is diagnose cracked teeth. So this picture is on my website. It was from a friend on Instagram because I thought it really is illustrated so well here. You can see that old amalgams, especially when they're 30 years old and have been working in patients' mouths for decades on end, they'll propagate, right? Because these are essentially non-adhesive restorations. And so functionally using them over one's lifetime will propagate, craze lines, and they'll become cracks. So you can ultimately, over your lifetime, fracture a whole cusp. And the extent of those cracks are really where I come into play, because sometimes these can become symptomatic. You can see with light, if you ever had a flashlight and held your flashlight up through your hand, and your hand glows, right, in a dark room. I think we all kind of did that as kids. The tooth, a virgin tooth or a non-cracked tooth, should glow through and through. Whereas if there's a crack, you can see from this picture, the light is on the lingual side and it does not shine through the whole entire tooth. And that's because the tooth is cracked here. Usually these teeth cannot be saved with a root canal. These teeth have to be extracted. If you do a web search on dental vitality testing, especially since you couldn't see my videos, a lot of stuff comes up. There's so many good tests, and really, like, this is where a bulk of my day is spent, like on testing teeth. There's also a hot test. I would say I do the hot test probably maybe 3 times a year, and you warm a stick of plastic, which is gutta percha. You heat it up to around 200 degrees, and you place it on a tooth. And if the heat causes symptoms, because again, it shouldn't, then that is the tooth that needs the root canal. So some new technology in endodontics, whether it's new, or it's kind of been around for the past decade and a half, but it's becoming more mainstream, is the cone beam machine. So it's the 3D scan within our own office. So I have a machine in my office. The latest version that Cavo has is the OP3D, which is similar to my version. And basically it's a 3D scan of the patient's jaw section. So I am usually taking 6x4s, but my machine can also take a 6x8 area. And so it's basically like what you guys might know as a pan, or if you had braces, you know, any of that imaging that circles your head. And what I can do is I can recreate what the patient has in 3D. And along the way, obviously, I love to find out what is causing their pain. But sometimes you can find some incidental findings, which are kind of fun, like this submandibular stone, which made this patient kind of, his neck would distend and he would back up with saliva because this stone was blocking his salivary duct, his submandibular duct. So some other things from the 3D scans are this patient's loss of bone. So you can see this is all good bone, and this hole right here is where this patient has his infection. Same thing with this patient. There's a hole in the bone right here. And obviously, like, this is what I look at, and it's taken me quite some time to get decent at looking at these images. But this is where a good chunk of your learning as future dentists will go to. And if any of you can get experience with this stuff, we were just learning 3D cone beam reading in residency, and we barely got any of it. So this is probably the hugest learning curve that I've had to do since I've graduated. But it's really so useful because x-rays are 2D, right? And they don't really show you what's going on all the time. So your dentist can say, I don't see anything, I don't see anything, but it's there on 3D. Some more about 3D. So the coronal plane is like if you were to cut the front and back part of your body. So this is an image that probably did show up on the x-ray, but probably was very vague. But you can see in 3D, this huge resorptive lesion is clear as night and day. Same thing on the sagittal, which is being split this way. And then the axial, which is split this way. So oftentimes now, what I do in practice is anytime somebody needs a redo of a root canal, there's no conversation. I won't redo a root canal anymore without a scan. So they're taking a 3D scan. And the reason why is because there's a reason why I have to redo that root canal. But I'd like to know why. And sure enough, again, if you can imagine a 2D x-ray, so a conventional periapical film, a conventional x-ray, would show this tooth as having a root canal, and it would probably show it being perfect. But what you can't see behind that, right, on the 2D, is that there's a missed canal right here. So usually there's a reason that a root canal is failing, and I want to know why. Sometimes it can be cracked. So then guess what? Probably 10 years ago, I would have gone into that tooth and maybe have seen a crack. This way, I don't have to go in, waste my time, waste the patient's time, waste the patient's resources. I can just say, listen, I'm pretty sure it's cracked. You should probably get an implant. And it's an expense, but it really kind of saves everybody a lot of time and wasted resources. This, for example, is another scan. So you can see on the x-ray again, this did show a lucency, but now you can appreciate the extent of the damage here. This is a huge lucency, and the tooth is resorbed and has also an area of internal resorption as well. And then this was the same tooth that incidentally picked up that cyalolith, that submandibular stone. Some new technology in endodontics, and again, I'm being really loose with the new technology, but obviously pretty much most endodontists work with a microscope. I think a new part that we're about to embrace is piezotomes, which typically periodontists have used for bone surgery, but a lot of endodontists are getting a lot of training on piezotomes because they can it can create a window so beautifully instead of our burrs. For a long time now, pulp regeneration has been one of the focuses of endodontics to avoid root canal therapy. And then materials, some advances have been in bioceramics because they have been shown to be so biocompatible with how we try to save teeth, as well as membranes. So I've been fortunate enough to start using the Snoasis BioExclude, which is basically human placenta, and I use it in surgery to scaffold like it's a membrane, so to cover the defect. I've also used it in the past to create an apical barrier where a child's root has not formed, so to kind of make a stop for me to be able to do the root canal therapy. And then again, what I have been doing since residency, but it's becoming more and more mainstream now, is intentional or surgical replantation. So truly taking out teeth and putting them back in, which is really cool. Working with orthodontists to pull teeth up or down to create sometimes when we have to repair defects that are subgingival or subosseous, that is indicated, or if there's dental trauma and the tooth breaks in a subgingival or subosseous manner, we can either take it out or you can have the orthodontist pull it and move it into place. And then again, auto transplantation, which is moving somebody's tooth to another spot in their mouth for various reasons. Either they're congenitally missing it, they were born without it, or the tooth was lost or is going to be lost because of an infection or a crack or trauma or whatever. So all of those are really exciting, kind of cool things that I think we do in our specialty. If you wanted to learn anything more about, I have written articles about autotransplantation and surgical extrusion. You can pretty much Google my name for a few of those articles. So a few things that I had wished I had known about endodontics before I had started. So I like to tell this funny story where, I went straight through. So that's not always typical that somebody goes to college and then dental school and then right to endo residency, especially. So I went straight through. So I like to say I've never really had a real job, and I've never really kind of been, other than my dental trauma, had a lot of dental work done. So I really didn't get what the big deal was about going to a dentist. And I always kind of enjoyed going to the dentist. Well, guess what? Like 90% of people in America really don't feel the same way. And I guess I got the memo super late. So what I didn't realize was I went through all this schooling and, I'm like, here I am, my first month of being an endodontist, and I'm so excited and I can't wait to start. And more so is when I opened my own office, but like you think that you've gone to school for all these years and that people are going to be so excited to see you. And guess what? They aren't. They don't want to see you. They don't care if you're pleasant. They don't care. Even if the root canal were free, they just don't want to be there at all. And that was really a memo that I got quite late, even after I graduated. Because in the academic setting, you're kind of sheltered from that, right? Like patients are there, they really don't give you a ton of feedback. But what I really had learned more, especially when I traveled as an itinerant endodontist, was people really like their dental home. Like they love their dentist. Some people aren't enthusiastic about going, but they love their dental home. So when they're told as a patient that they need to leave their dental home and go see a specialist who they don't know, and especially a root canal specialist, which like has like the worst stigma in the whole wide world, um, we get referral slips like from like a year ago, a year and a half ago, and they're just sitting on this referral slip, not wanting to come and see me. And then after they come and see me, most of the time they're like, that wasn't so bad. And I'm like, yeah, duh, you know, but everybody still thinks that root canals are the worst thing ever. So that's kind of, I would say, the biggest hurdle about practicing every day. Patients are still very anxious. The myth about root canals is still very, very present. They don't want to be there. Even afterwards, it like, let's say a patient has a great experience, you've won them over. If they really needed a root canal in like, you know, a year later, they'd still hesitate to come. That's just how strong the stigma is. The other thing is that people wait and wait and wait and wait. And the big thing with my specialty is its unpredictability in terms of our schedule, our daily life. And I think it's gotten worse, especially in the past 5 years with the advent of urgent cares and everybody being accessible all the time. You know, like a person will walk in as an emergency, you know, call, of course, but they'll come over as an emergency at 4 o'clock and really not feel badly at all, like that they've waited and waited and waited for, you know, sometimes they'll tell you 3 months or 3 weeks or whatever. And it's just like, why didn't you just get this taken care of before? Why didn't you call this morning? Like, why are you coming at 4 o'clock in the afternoon? But that's just human nature, right? To put everything off. So the emergency aspect of this specialty is substantial. You know, we kind of don't know what our next week or next day is going to look like ever. It can change at the drop of a hat. So I did want to share, with all of that being said, that some patients also, you know, end up having great experiences and fall asleep, and that's what we aim for. We really, but the other day somebody had, they must have had like a fit watch or something on, and he said, my stress level is at a 2. It's never been that low. And I'm like, that's great. I don't even know what a stress level of 2 means, but that's great. And that's what we want them to feel. We want it to be a very relaxing environment. We want them to, you know, fall asleep. That's a huge compliment to me, right? And in my team, that we are so comfortable and relaxing that the patient fell asleep. So with that, I wanted to just share a few cases with you guys. I know I only have a few minutes left, but so while this looks like a straightforward endo, I would say that this is these kind of cases I get maybe one handful a year. And as easy as this looks, because it's a straightforward one big fat canal, it takes a lot for me to do this really well, because I'm so not used to this amount of space that I need to work with, because most of what I see is literally so much smaller. So when I have to do this, it actually ends up being harder than it looks, but this is considered an easy case. And so for everybody that really doesn't know anything about this specialty, so the gray line is the nerve inside. Let me go back. The gray line is the nerve inside. So either it can be still somewhat alive and inflamed, or it can be totally dead inside. And so I have to get in there through making a hole either on the top part of a tooth, like a molar or premolar, or the back side of a front tooth, so that the patient doesn't see the access. And then I get inside and I clean it out with files and salt solutions, disinfecting solutions, mainly sodium hypochlorite, which is also known as bleach, and other solutions. And then I fill it with plastic, and this is called gutta percha. And this is basically my life, white lines. So you can see here that it was kind of, again, this is considered easy, but nothing's really that easy. And then it totally gets closed off and then opens back up again. You can see that it's really closed off. So I had to get through this blockage. And those are pretty much the obstacles that I get through all day long, besides the patients and patient management. So again, this tooth has 2 canals. You can see the 2 and joined into one. And, you know, these are white lines, and white lines are what endodontists do. So this would be a medium case, not because it wasn't an easy root canal, but like you can see, well, what you don't see on this x-ray are that there's gum here, your gingiva. So this person had decay under the gums. So you have to isolate and then prevent saliva and blood and everything else you're dealing with from getting into your, space. And so I built up a wall here and then did the endo through the side so as to save as much tooth structure as I could. And then I filled it. And this was the lateral puff and the lucency at that time. This was clearly an older film that we had gotten from the dentist. Again, these are now getting into hard cases, but this was a tooth that had trauma many years ago. Was discoloring, so we also bleached it from the inside. But this was basically my access, and you can't even see a canal in here, right? So like this tooth next to it, you can see the canal. Here, there's nothing in here, and I basically had to find my way this whole time. I will tell you what I did was once I accessed it, I was so excited about that I got in, and it was, oh, bingo, bullseye. And I broke a file like right off the bat, like within the first 5 minutes of getting in. And then I had to get that out. And then thankfully I finished the case without any further incidents. Again, a big part of my practice is trauma. This young girl fell while riding a bicycle and basically shattered her teeth. This is one of my publications. So if you want more information, feel free to look on Instagram or in the publication. But this tooth ended up having fragments, like 20 or more fragments. And I pulled out the teeth because there was nothing left after I took out all of the fragments. I pulled out the teeth and repositioned them. And so this girl could have somewhat of front teeth and then build them up again. So literally I took the teeth and lowered them just so you could have something to see for this girl. And I did the root canals. So again, canal space, you can see canals here. They are tight. This is how it finished. You can see these are skinny, small areas that I work in. My files are pretty small. Everything is mostly done by hand at the beginning, but we do have, like I said, our endodontic motor, and that's very helpful. But this is definitely hard work. I put this in as a medium case only because this tooth, this is pus. This is a different tooth that was draining full of pus, and it drained over 5 visits. And she just kept on coming back and coming back and coming back. She went to the hospital. Her eye was swollen shut. And it's not that it's technically that difficult, but you want the pus to stop. And sometimes you just can't overnight. And the patients get really exasperated and out of patience. And you just have to, really try to reassure them that it will get better, because the other option is just pulling the tooth. Ultimately, removal of the tooth will remove the infection. It will put an end to the problem. And honestly, some people don't always have the patience to work through these kinds of situations and will pull the tooth. So it is a very real alternative. Again, a medium case. For hard cases, you can see that this is a tooth with a post. and a silver point, which is the old school root canal filling material. So I had to take out the silver point. Silver is very, very malleable, very it just can break very easily. So I had to redo this entire root canal and do this root canal because this one had an infection in it as well. This was definitely, these were not too easy teeth right here. Again, a picture from surgery. So this lady had an infection on 2 of her front teeth. This is the incision in the gum that I made, reflected the gums, hold back the gums, and then from upside down, make a little hole at the inside of the tooth's root and then plug it with bioceramic putty or MTA or something. So you're kind of sealing off that area of infection. And I posted that she has completely healed 6 months later, which is amazing. Again, not an easy case, but a lot of what I see are previous root canal failures. So in this case, there was a broken file. This is the file that was in this lady's tooth for, I think, 3 years. She had originally come to me for a consult over a year ago, and then just called recently, and she was like, all right, let's do it. And you could tell she was still just bitter and sour and mad about this broken file. And she did know that it was there. So some people don't realize that it's there. But she was still mad about this broken file and still hurting. So she was just not happy. So I removed the file in one fell swoop. This was the tissue that was still attached to the file when I took it out, which is pretty darn cool. And then I put medicine in and had her back several weeks later, and then I finished the root canal. So it's almost like I feel like I'm in construction, and this is the reno, right? Like this is demo and then renovate. I know you guys might be interested in what my schedule looks like. If you remember, I work out of one chair. So for example, this was my Tuesday this week. So I retreated and placed the filling for tooth number 30, which is the lower right first molar. I changed the bleach on a lower incisor for this wonderful patient. So really just a quick visit, just changing bleach, because that's also a part of what we do as endodontists. I started the root canal on this tooth, number 3, upper right first molar. And then I started a root canal on number 19. I also took a scan, which takes time. And then that was my Tuesday. Here was my Monday. Again, this happens to be a super light week. It was a drain. So again, make an incision, drain number 19, scan for tooth number 21, and a consultation. So I'm doing the pulp vitality tests during those consultations, completing number 30, lower right, consult number 19, consult scan number 11. And then just to show you how something can get crazy really fast, my last Thursday, which just was totally, totally nuts. I ended up, I think, going to bed at 8:30 that night because I was just exhausted. So this was an emergency, this was an emergency, and I think this was an emergency. So you can see how quickly your day can change. This was our column up until 4 p.m. and then this was all added to it. So it really changed, and it makes for a little bit of stress definitely during your day. So I hope that all has been helpful. I think mainly my advice, and I'm sure I was told this also, 20 years ago, but really I can't emphasize it enough. Get to know insurance, get to understand coverages and plans and how to run an office, understand dental software, where to go. I think also, as everyone is transitioning either from college to dental school to residency, whatever, just really try to get to know yourself. What do you want? Where do you want to live? How do you want to work? Do you want an associate? Do you want to own? Do you want to be an associate? Do you want to have a partner? Do you want to work for a big corporation, or do you want to work in academics? The sky is the limit really in dentistry, but what works best for you and your personality? And then how do you want to practice? Like I know that my first job, my boss was amazing. It was a medium-sized practice. We were both very busy. I probably would have been very happy there the rest of my life, but I moved away. So I like the way that I practice now. It's, a small practice. I don't really care much about meeting goals, daily goals. I just want to do good work and I just want to go home. I know I probably wouldn't like a large, personally, I wouldn't like a large office. I love that I can see 4 or 5 people in a day at the very most. Obviously, last Thursday was a bit nuts. During residency, I worked in a pedo office doing their root canals, and it just was nuts. It was a lot of craziness to me. So I just knew that I probably wouldn't like that type of practice environment. And also, what are you good at? Are you good with gums, and are you good at surgery? Then probably, surgery or perio is for you. If you're really good at your hands and love lab work, I didn't love lab work, even though I was really good with my hands. Everyone thought I was going to go into pros, but I just knew I just didn't want to do tons of lab work for the rest of my life. So getting to know what you really want out of your daily practice and lifestyle really will help gear you to your right specialty. So just thinking about all of that will really help. So thank you so much for having me. I really appreciated all your attention.
Yes, thank you so much, Doctor. That was very informative of a session. I learned so much about endodontics from that. So thank
I'm
you so
glad.
much.
Awesome.
Yes. Yes. So we're going to take a few questions before we end today. The first question is, what do you think is the hardest or most challenging part of being an endodontist?
I would say mostly it's the patients and talking everybody down off that ledge, right? Because they're just so anxious when they come to you. I think that is probably the hardest part. Trying to reassure them that you're not going to hurt them, because they really firmly believe that. I always try to tell patients, like, listen, just raise your hand the moment you feel any discomfort. But it should be like any other dental visit, but you can't reassure them enough, and it takes a lot, like it's just kind of emotionally draining throughout the day.
Mm-hmm.
To talk everybody down off that ledge. So it's nice when I have some starts, some consults, and then some completes, because then I know the completes are people coming back. They already, for the most part, have my trust. So that's always nice. But it's every new patient and trying to figure out, their history with dentistry
Mm-hmm.
and where they're coming from, and trying to allay all their fears and that you're not going to hurt them.
Mm-hmm.
So that's probably the biggest challenge. Technically, of course, I would say in terms of endodontics over, my career, it definitely hasn't gotten easier. I'm doing more retreatments. I'm doing more surgeries than I did at the start of my career. Whereas I really thought I was just going to do bare bones, start to finish endo virgin,
Mm-hmm.
first time endo would be the most of my practice. And it's just not anymore. It's really a lot of redos.
Mm-hmm. That makes sense. The next question is, can you explain your planning process before opening your practice? Did you have a business planned and or patient scheduled before opening your doors?
Yeah, that's a great question. So I think when you go to apply for a loan, right? So like there might be a few people who can just afford, to open a practice without a loan. But when you go to the bank and ask for a practice loan to open, right? Um, they want to see your business plan. So they're not going to give you any money without a business plan. I kept my itinerant jobs for the first, I think, year while I was opening. So it was very stressful because what I would do is I would work, 2 days a week somewhere else, and then either see my emergency patients at my office in the evenings or on my, other days. It's just a lot of piecemealing your life, and having, obviously a supportive family, supportive friends network, to get you through the opening phase. I will say, obviously 5 years ago, to open a 1,000 square foot office and plumb it start to finish was about $800,000 estimate. So I don't want to give you guys any icing on the cake. It takes a lot of money to open a practice. That being said, I know that some of my friends have bought practices and they're more too, but you're ready to go and you don't have as much blood, sweat, and tears. And there's a lot of blood, sweat, and tears in opening your own too. So I hope that answer was sufficient. But yeah, you do need a business plan, and you definitely need to. You're not going to be busy from day one if you're opening from scratch. You're just not. So keep your other jobs.
For sure. The next question is, do endodontists have a high level of background in neuroscience or neuroanatomy?
So we do have to take a lot of pulp biology. I wouldn't say specifically endodontists have more in terms of that. Obviously, there's a certain curriculum to get your master's or your certificate in endodontics. So there's a standard curriculum. I don't know that in endo we had any more, so in terms of more neuro than any other specialty. I don't think so, but obviously we also would do pulp biology, and there's definitely a heavy pulp biology in terms of our literature, in terms of our residency curriculum.
Gotcha. The next question is, can you go into the work-life balance of an endodontist from your experience, which I think you explained throughout.
I mean, I'm happy to just discuss it for I'm obviously, I think, an outlier among my friends. I only work 3.5 days a week. My family would tell you I work 7. So it all depends. I only see patients 3 days a week, but I'm always working. Some of my friends, so my first boss would work 4.5 days a week. Everybody's kind of different. I think that it depends on the type of practice you have, the type of staff you have, and also your outside interests. Like, there's a lot of people that just can walk out the door and not think about anything about work after they walk out the door. I'm just not one of those people. So it's a little unique to each person. I would say most endodontists are pretty particular. I would say we as a whole do, we don't always leave work at home.
Mm-hmm. Gotcha.
So we don't always leave work at work, excuse me.
Mm-hmm. And then the next question is, what are some things that might obstruct the retreatment of root canals?
So canals can calcify. So when a canal closes itself off, like in I think that's working. Oh, okay. So like this could be a complete blockage. And also, this, in this case, I had a scan. So my outline was planned in 3D, whereas in 2D, you don't know you make your hole, but what if the canal is right here, right? So you keep going this way and you come outside the tooth. So these calcifications are literally like cinder blocks. It's like you're hitting a wall of complete blockage. So this is really hard. again, I think I told you in this case, it was so hard that I broke a file, even though I was straight into the canal. And then I had to get that out. So in terms of retreatment, like it's calcifications, it's curves. Like I had this one curvy case a few weeks ago. Literally, it looked like this. Like it had like 3 bends that looked like S's, right? 3 of them. I did not get down. I did not get down. And we actually called her today and she's feeling fine, but I know I was 6 millimeters short on that tooth because it looked like, you know, I want to say Lombard Street in San Francisco. It was just so curvy. Those are, so anything foreign or a blockage from the body would be, or a curve is really the major impediments when you're trying to do a root canal, a redo root canal, and then obviously the blockages for fresh root canals.
Yeah, that makes sense. The next question is, did you take any art classes to help with your dexterity and precise hand movements?
So I didn't. I thought that this question might come up. So what I did growing up was I did a lot of like jewelry making and like beadwork and just like a lot of like little things like that. I'm not sure if they still have the perceptual ability test on the DAT. I would imagine that they do. I mean, I don't know. Can you practice for that? I'm not sure. I mean, obviously you can take practice tests, but I think my things with my hands, I was always really good at. And then like in terms of spatial ability, I was pretty good at. So I didn't have to do that much, but I think all of dentistry really does take a lot of hand-eye coordination and some precise movements. So obviously it helps if you are good at that too. But I wouldn't say necessarily practice something you don't love either. So.
Yeah. So then the next question is, when would you use the hot test over the cold test?
So when someone comes in and they say, "Oh my gosh, coffee is killing me." So it's usually 3 things that I like to discuss about hot. So have you ever had like a hot piece of like melted cheese and you're like, "Oh my gosh, that's so hot. It like would burn the roof of your mouth off," right? So when someone has a toothache, that hot cheese pizza will hurt. But remember, on the lower parts of the jaw, and sometimes on the tops too, but mostly on the lower, because they share the inferior alveolar nerve, sometimes they can't localize which tooth it is. And also, you never want to take the patient's word for it. So you have to figure it out, right? So when you get the hot gutta percha and melt it on each of their teeth, you can figure it out. Because remember, with a root canal, it's not like a filling that even if you do the wrong tooth, it kind of doesn't matter. Like it's a root canal. Like you can't fix it. Like you have to, once you start it, you have to do it. So if you have diagnosed the wrong tooth, you still have to do the root canal. And then you have to do the root canal that was supposed to be done on the right tooth. So it's not something that you want to get wrong. So when people say that hot has been hurting them, a lot of adults will say hot coffee, like when they drink coffee in the morning, their tooth hurts. Or like a French fry, a hot French fry, if you've ever had a hot French fry, if the French fry hurts, those all, I don't keep French fries in the office. I don't keep hot cheese pizza in the office. So I need to melt the gutta percha and make that hot.
Yeah, no, that makes sense. And so I think that is the time. That's all the time we have today for the questions.
Great.
But thank you again so much, Dr. Judy.
You're so welcome. And again, if anyone wants to message me, that's fine too. And thank you so much for having me.
Social media.
Oh yeah. Yep.
Yeah.
So
that'd be awesome.
is right here.
Awesome.
Yep. So on Instagram, that's my handle.
Yes, your session was so informative and I love watching it. Thank you to the viewers for joining in today as well. Again, just a reminder, the quiz will be found in the live stream chat, the group me, and the link tree in our Instagram bio, and it'll remain open for 12 hours. So again, thank you guys, everyone, for coming out and watching. Thank you again, Dr. Judy, for joining us.
Thank you for having me. Have a great night, everybody.
Great night, everyone.
Bye.